za dolgo ali kratko pot. Zdaj lahko poskrbim za svojo družino, ker moje gorivo poskrbi za moj avto. Izboljšani dodatki v gorivih MOL učinkovito zmanjšujejo obloge in tako čistijo motor. Z novo generacijo goriv MOL Evo poskrbite za motor vašega vozila.
Tell us about the hip and groin pain in athletes, how updated you are. So please, Theodora.
Thank you very much, Mr. President. Thank you everyone for being here today, this early morning. I appreciate this after the last night. It's difficult. First of all, I would like to say a big thank you to the organizers for the invitation and for us being here in this beautiful place in Portorož. It's a great honor. I'm Dora, you can say this. I'm an orthopedic surgeon and sports medicine consultant. I'm privileged to work in an amazing place with Dr. Ed Sellon in the Defense Rehabilitation Medical Center in the UK. And I work mainly with hips and the groin. And I lead a big hip study. So why we're here today? First of all, I want to say that all together, all the speakers, we did a bit of work together to make sure that leaving this place today, this hall, you have all the information you need. It's not a rocket science, it could be a simple thing, but what we will try to do is to simplify in your head all this about the complicated area about the hip and the groin. I'm going to concentrate on the groin, and we will change a bit the order. Next will be Dr. Sellon, who is going to talk about the imaging of the groin and a little bit of the hip, and then Dr. Clement will concentrate on the hip and the treatments. Any questions at the end, we will be happy to take them. So the hip and the groin is a very complicated area. People like me, old people, working years in that field, 10 years ago, 15 years ago, we didn't know much about the hip and the groin, the athletic hip and the groin. All I knew as a surgeon, as a young surgeon about the groin is, doing hip replacements at this time, it's a big joint and all this. The last 10 years, the last 15 years, the last 10 years, we do know more. When we talk about groin, though, we still have to learn a lot. Now, I always like to start with this complicated picture. Groin is a very complicated area. And I always ask my students, in few seconds, not in a minute, can you identify the panda in this picture? Obviously you can in the beginning. It's so complicated, but then if you focus a bit, you can find it. And this is what we will try to do today. We will try to add a focus in an unclear world. Hopefully we'll be able to do this. Well, why is complicated? Because it's an extremely complex anatomy, mixed and coexisting pathology conditions. Many times with the groin, we have a mix of coexisting pathological conditions. And as Ed will say later on, clinical and diagnostic findings are not always in harmony. So, and on the top of it, you have this complicated neural or nerve supply causing this referred pain. And I have to say that very often I see in my clinic people with testicular pain, people with perianal pain, and maybe you do the same, because we have the complex nerve supply. What we need to know in general, for every injury, our anatomy, our pattern recognition, mechanism of the injury, symptoms and signs, and of course your diagnosis. Is it an acute? Is it long-standing? It makes a difference sometimes. And then of course the principles of the management and rehabilitation. But is there anything else, which is a very complicated area, is there anything else we need to know? What I can do today to make your life easier, as other people did for me. So I'm not going to talk about anatomy today because Ed Sellen will do this. But if you find it very complicated and you want to start from one thing, know well your anatomy of your adductors. Why? Because the adductors are the commonest injury. Very complicated anatomy, many superficial layers, and a lot to learn in the next year. Okay? Only to say that the tendons and the muscles, they don't sit loosely over there. They have deep interconnections to the pelvic bone, and that's why things are more complicated. And this is what is coming the next few years. I'm not going to talk about this because Ed Sellen will talk about this. Remember one thing, many superficial interconnections, large muscles there and large incisions. That makes a difference for the adductors. And again, for iliopsoas, just remember that we have the iliacus and the psoas there makes a difference because the iliacus is often involved in these injuries, and very often we see higher up injuries to the iliacus. So it's not only the iliopsoas. Now, we understand now that it's a very complicated area, and obviously I'm not that clever. Someone else understood this before me. And 2013, years ago, people who were more clever than me, they said, this is a problem here, we need to do something. The terminology is very complicated, the groin area is very complicated, let's see what we can do. So they had this idea about creating a common thinking. So they thought that they're going to build an agreement using a sword Delphi method. And they thought that if the terminology is not that confusing, then we can live easier life. And why is this? So what they did, they invited 24 experts from all over the world working groins, all the experts. I've not been there. 23 international experts, 23 answers from them. They asked for a single diagnosis for a single condition, one condition. 23 experts, 22 terms for the same condition. So then they said, yes, this is a very confusing situation. We need to do something for this. This is 2013. And then we had this discussion yesterday in one of the halls. Do we say the same things in a different way? But yes, we do, because this is the many words for said. Does it make the difference? It does make a difference. We learned from the study. There was a study 2 years ago saying a systematic review looking at the terminology, if the words do matter, and how different terminology for the same influences, for the same condition, can confuse people and can influence the management preferences. And what happened then? We understand now that it's the first step. We understand that it's a very complicated area. We understand that we have this heterogeneous taxonomy for the groin injuries, which adds more confusion in this already complicated area. They met all together, 2014 in Doha. I was lucky to be there, say again, delegate, not one of the experts. And they created the Doha Agreement in Aspetar meeting for terminology and definition for growing pain in athletes. So, and this is the first step. And the second step is looking at this terminology. Is this going to make our life easier? So you can find, the time is limited. I have to tell you so much. So everything is in this British Journal of Sports and Exercise Medicine. It is available online and it is free. If you have any problems, come and find us outside. Okay, so you can find everything in here. So what is the next step? We finish all this, and what they agree? They agree, after all this confusion, that they should to use a classification system. And they agree to use this classification system for the growing pain. And nowadays, this is what we use. Adductor-related growing pain, iliopsoas-related growing pain, inguinal-related growing pain, and pubic-related growing pain. That's it. Forget the fancy terminology. Only adds confusion. And of course, the very important part, the hip-related growing pain. We know that the hip can cause, can give us growing pain. And of course, don't forget your other causes. Red flags are important. Don't forget your red flags. All right. And then what we did, so that's the third step, to go further when we have now your classification with the clinical entities. We went and we've seen the clinical findings on this. So for we have particular clinical findings for the adductors-related growing pain, for the iliopsoas-related growing pain, for the inguinal, and so on. We'll see some pictures later on. So I think that already we make things in our head a bit more clear. Then when we do next, we know the entities, so we have the 4 entities. We try to systemize, let's say, our clinical examination based to this classification system. So 1, 2, 3, 4. This is what you do if you like the system. And again, it's free online. To say here that all these are mainly for long-standing growing pain. Okay. And back to the 4 entities, adductor-related growing pain. What we feel is that with adductor-related growing pain, they will have pain in the adductors. They will have pain in the resisted adduction. And I would like to thank my team, Robin Cassidy and Matt here, my physio and my exercise instructor for the pictures. With iliopsoas-related growing pain, they will have pain in with the palpation around iliopsoas. And tests, most likely they have the problem if they have pain with the resisted hip flexion and pain with the hip flexor stretching. So it's not a rocket science, right? It's a simple thing. With the inguinal-related growing pain, we have pain in the inguinal canal, and most likely we have pain with Valsalva, cough, sneeze, and resisted abdominal. We should resist here. Here to say, most of the athletes, they don't have hernia, okay? With the pubic-related growing pain, we don't have a specific test, but they have the pain in the pubic symphysis. So, I'll go later on this. Diagnostic tips for acute pain, because the time is very limited, I would recommend to go to the thesis of Andreas Cerner, who did his PhD on acute growing pain, and it's a perfect one. You can find it online. If you don't have the time, come and find me later on. You have all the information you need there. Again, this SOMU that I don't have much time. The sports, we see the acute injuries, kicking, changing directions. The imaging is negative to 20% of them. Two-thirds of them are adductors, and 90% is adductor longus. And I go again quickly. Infographics, they're amazing. So if you want to get a quick information, get your evidence base, get a good journal, and know the people in the area. So we have this infographic when you can really find many things in 2 minutes. A bit of epidemiology. Again, I'll go quickly because we don't have time. Mainly all the studies, the last 10 years, adductor-related groin pain is the main groin injury, following by iliopsoas-related, inguinal-related, and then hip-related. Again, and this is for the acute. Again, adductors are first, and that's why I told you, know the anatomy very well. Well, what we do, I can't say everything in this speech, but I try to be quick. So for the acute adductors-related groin pain, we use the Per-Holmich protocol. Yes, it was published in Lancet 1999, 20 years ago. It still works. It's an amazing protocol. The multi-modal treatment of Adam Weir, and again, you have here some fantastic infographics, and there is an app with the pairs and protocol you can use online. With the long static adductor-related groin pain, again, we use a lot the Per-Holmich protocol, but be careful, some important elements to the program. Many repetitions, 8 to 12 weeks, 3 times weekly, 90 minutes. Avoid everything, can exacerbate the pain, and if they don't have the pain, they can go back in 3 or 6 weeks, but we see good results in 4 months. Do we have any other treatments? Well, okay, what about, I'm a surgeon, I should talk about surgery, right? Yes and no. If we need surgery, adductor stenotomy, it's a good surgery, and out of the 4 studies, 5-level 4 studies, variety study design, we have excellent results, more than 54%. We have poor 8 to 17, and complications 5 to 34. But look here, with the active exercise program, we have excellent 79. And what's happening later on? These people, they follow up these people 8, 12 years later, and again, with the active exercise program, they had better results, significantly better. With iliopsoas related groin pain, there is no current evidence of evidence-based rehabilitation program or protocols. What we do, we use the same protocols for the adductors as for the adductors. We add specific flexus exercises. We're starting with isometrics and slight eccentric. And when they are all ready, we're going to do the heavy slow. And in 6 weeks, they're doing well. Now, again, Ed Sellon is here. I hate the steroid injections. Do I use them? I do use them, but only for rehab purposes. So I will use steroid in the tendon when they're coming for the rehab. They're in a lot of pain. We cannot work on the strengthening, and then I ask Ed to help me, always ultrasound guided, and this is what we do. Avoid iliopsoas stenotomy in athletes. It's not working well. And then there is a very good improvement in 6-week times with strengthening your hip flexors. Treatment for the inguinal canal, inguinal-related groin pain, general advices, and strengthening the abdominals, very important, and the muscles around the pelvis. So I'm going quickly. I'm finishing. Remember, the majority of the athletes, they don't have hernia, but sometimes they can have pain arising from specific ligament. look at this area, what we call pubic clock. It's very important area. So what surgery we do with them? Common surgery for hernias, but we don't invert the sac in. But I'll talk you just, and this is the last slide, one specific surgery for those pains. The pain arises from these ligaments. Professor Lloyd in the UK, yes, when you pass the button to the knife, when every conservative treatment failed to improve the symptoms. Only then. Then Professor Lloyd created this procedure. What he's doing, 3 little holes, endoscopic. He's going down to the inguinal and lacunar ligament, look for tears, and will repair all those, and inflammation, and then down to the pectineal ligament, and if this is under tension, he will release this ligament. And he put a mess. And, well, the evidence is not that strong as yet for me, but those people I've seen, they have very, very good results. It doesn't harm. They stretch in 24 hours, and they go back to activities in a week. This is the procedure. Again, only when everything else failed to improve. And the pain they receive with this tension under the ligaments is around this area. Take-home messages. Avoid the fancy terminology like Gilmore's groin disruption. People are going back and they think that they need to be fixed. No. Know your anatomy. Develop your own clinical examination technique based to the 4 clinical entities. Get standardized with your examination. So when the serious pathology is not expected, the Doha Agreement guidelines are really good. For chronic related groin pain, okay, we don't forget, red flags and everything else. That's it. I'm not saying more because I need to pass the baton. Before everything, be sensible and trust your clinical skills. And this is the abnormalities found on scans in asymptomatic people. And I pass the baton to Edward Sellon and Clement, and I invite you in Glasgow, November 2019. Hvala for your attention. Thank you very much.
Good morning, everyone. So, Dora, thank you so much. It's a lovely introduction, and it's great fun working together on these cases, and they're hard cases. Groin pain is difficult. I think you'll agree. So, what I'm going to do, I've got a slightly different perspective, but essentially the content is very similar. Okay, so it's an imaging perspective, and I'm going to talk again a little bit about the classification, because that's important, terminology is important, and then a bit about the anatomy, because again, we can't get past that. If you're not really au fait with the anatomy, then nothing else really works. And then after that, we'll talk about the MRI and ultrasound findings. Okay, so groin pain, as I say, is difficult. It's difficult because there's such a wide set of differential diagnoses. And we need to remember that groin pain can be caused by hip, hamstring, lumbar spine, and sacroiliac joint pain. So these all sort of relatively simple, actually, but what's harder is this group of patients, where it's actually coming from the groin area. Long-standing groin pain, that's the preferred term. Groin pain is, or groin injuries are significant injuries in a lot of sports, but really particularly in professional soccer. And that's because you can see there's a lot of cutting and diving, one-legged kicking. And as you can see, it occurs in up to 1/5 of all injuries at some point. It's an acute injury that develops from a tendon tear, muscle tear, or an avulsion. And there's a significant proportion of patients who develop chronic long-term symptoms, hence we call it long-standing groin pain. And a recent UEFA study showed that there were 2.1 injuries per 1,000 hours of play, which doesn't sound like a lot, but actually it's the highest instances of all soccer injuries. Okay, you only need to stick it into Google to realize there's a lot of a lot of information out there, and some of it's quite confusing. As Dora said, sports hernia is a term that we like to avoid nowadays, and I'll explain that a little bit more later. So, what do you get with long-standing groin pain? Well, there's a gradual discomfort around the groin that starts around the groin and symphysis pubis, and it's usually worse in the morning, and it fades away as it warms up. And then this can progress to pain with exercise, then finally pain with rest. And who gets it? So it's particularly athletes who do a lot of kicking, like I said. And this is the number one feature, it's repetitive kicking, also changes of rapid, repetitive changes in motion. So the problem we have here is that when we look at the clinical literature, is that there's a lot of nomenclature and a lot of confusing terms, and actually all these terms listed here are exactly the same thing, really. So people talk about adductor tendinitis, groin strain, other things, osteoitis pubis, athletic pubalgia. But really, if we move over to the inguinal canal, things are just as bad. We could talk about disruption, dehiscence, Gilmore's groin, hockey groin, sportsman's hernia. These are misnomers, as I said. And there's a lot of nomenclature which started in the clinical literature and has spread over to the radiology literature. So another term that takes into account the many anatomical structures involved here is the term core injury. And the concept of the core has been quite well established now, particularly by Bill Myers in Philadelphia, who wrote this book on the left. And really what he's talking about is all the structures between the chest and the proximal thigh, the mid-thigh, actually. And that allows even sort of subclassification into the structures involved, such as muscular, hip, back, and everything else. So four subcategories. When I think of the core, I think of my own underdeveloped and overused core. But actually, we're opening the picture a little bit to the proximal thigh. So just touching again briefly on Doha. So remember that Doha was very much an appraisal of the clinical entities. And from a clinical point of view, this is what we got. We got 4 categories. And they were adductor-related, pubic-related, inguinal-related, and iliopsoas-related. And if you read the paper, they explain quite clearly that how to examine each of those different pathologies. But actually, it's not helped by the lack of gold standard. And also, the clinical difference between adductor-related and pubic-related pain seems quite minimal to me. And I think that those things can be quite safely considered together. So, in reality, what do we see? Well, for me as a radiologist, excuse me, the referrer usually sends a patient along. So, Dora will come and say, this pain is adductor pubic related, or I think this is inguinal related. Iliopsoas related pain is pretty rare, so I don't really think about that in the same way as I think about the other two things. So really we're left with the 2 problems. And you can see that the problem with this is the referrer, Dora's side obviously, is usually biased. Okay, so you've got to be aware that there is a great big bias at play. And that's because clinicians who see a lot of inguinal pubic pain will tend to think, or at least those who've been trained by somebody who treats a lot of adductor pubic pain, will probably call the groin pain adductor pubic again. And those who've been trained by an inguinal surgeon will likely call it inguinal again. And actually there have been studies that have shown when the same patients have been seen by different specialists who have been trained by different specialists, the same patients gets sort of classified one way or the other. So actually it's really unclear. So really the take-home message is, from the clinical stuff, there are 2 main groups, okay? There's the adductor pubic group and there's the inguinal group. But you can't really trust that, and you've got to have a bit of an open mind. And the next thing to remember is that when we look at these 2 groups of patients from an imaging point of view, we find lots of pathology around the adductor pubic area, but we don't see very much reliable pathology around the inguinal canal area. So that's another issue. So a little bit about the anatomy now. So the anatomy we're focusing on is all around the symphysis pubis and the groin area. And we know that we have the rectus abdominis, the pyramidalis muscles coming down to the pubic symphysis, and we have the adductor longus tendon coming down from below. And at the sides, we have the inguinal ligaments. You'll all be familiar with that. And this area acts as a strut between the lower limb and the spine. And this is where the tensile forces pass. And there's an anterior pelvic tilt that has to be maintained with effective athletic motion and kicking. There are also shearing forces across these tissues, and these are exacerbated excuse me, when the athlete goes into a single stance. The pubic symphysis is a fibrocartilaginous joint. It has a disc which is similar to that of the intervertebral disc in the spine. It absorbs and transmits shear waves across it, and it has a primary cleft. And as you can see, it also can form a secondary cleft. The black arrows here point to the hyaline and fibrocartilage in the middle, and like all joints, it has a lot of ligamentous support. Okay, so you've got ligaments anterior, posterior, superior, and inferior, and they cross the joint in the midline. And some of these ligaments are continuous with the disc, and they surround the muscular attachments and the muscular origins, and they support the overall stability of this important, excuse me, anchoring structure. So if we compare this image with the one from 2 slides back, you'll see that it's actually much more complex. Okay, so we don't have these discrete attachments from those 3 different angles. In fact, what you have is a mesh of tissues that all come together on the symphysis pubis, in fact, over the symphysis pubis. And if we look at the MRI scan, we have 2 main vectors at play here, from the transversalis and abdominis muscles merging with the adductor group from underneath. And adjacent to it, we have the pubic ligaments sort of coming from the side. Okay, so this leads to a prominent aponeurotic plate, and it's this connection with the distal rectus abdominis attachment, the pubic symphysis and the adductor longus origin, that gives us this common aponeurosis that can get injured. And very close by, circled in blue here, they're the close anatomic structures, the borders of the superficial inguinal ring, which may explain why inguinal hernias or inguinal hernia-like symptoms in patients are so confusing in patients with athletic pubalgia. Okay, so even though true hernias are absent in these patients, you can see why little defects in the fascia here clinically is almost synonymous with defects of the adductor longus and aponeurosis. And just adjacent to this, to the growth, you have the growth plate. And the growth plate in these adolescents, in fact, not even adolescents, people up to their mid-20s, this is difficult because you've got a growth plate that varies with age and doesn't close until very late. In fact, it's the latest site of secondary ossification to fuse in the body. And on CT, you see this interdigitating structure that finally fuses in the mid-20s and can cause quite a lot of radiological diagnostic uncertainty. I think you've got to remember that when you see on X-ray or CT this bony irregularity, even on ultrasound, it's normal. It's normal up to probably late 20s. Okay. So pubic apophysitis should be considered as the differential diagnosis, of course, but groin pain in the early 20s is unlikely to be related to this appearance. Okay, so moving on to MRI. So the important thing when you get an MRI scan is that you need to know what you're getting, okay? So what's important is you get small and large field of view images, okay? So this is what we do while I work. And the radiographer starts with the large field of view axials, and you see this here and here. And then they do a small field of view sagittal, and you can see that here. And then they draw a line in order to plan the oblique axials. And it's these oblique axials that are most important and also most often forgotten, okay? This is where we get all the information here, okay? So what do you see with this? Well, sometimes you see degenerative changes around the symphysis joint, and these cortical changes, as I say, are generally ignorable, okay? We see them very commonly, particularly in the young, particularly in the sporting population. So I would urge you to sort of brush past those pretty quickly. What else do we see? So pubic bone marrow edema. Okay, so this can be associated with adductor tendon edema. It can be associated with perisymphyseal soft tissue edema and fluid in the symphyseal cleft. But again, this association is difficult and it can be a normal finding in athletes under 20. Okay, so this is usually a self-limiting stress reaction. And the point is that unless it's quite severe, again, we tend to brush over it a little bit. Fluid in the secondary cleft. So there are clefts caused by pulling away of the capsular plate, either with tractional pathology, by any of those structures that we've talked about. And these correlate actually quite well with pain. And you've probably heard of terms like secondary cleft and superior cleft. And we don't usually distinguish between those structures. It's not that important. But they are predictive of symptoms when we see them. So if we see them, then it probably is important. And the important thing to recognize is that these clefts they're usually associated with symptoms, but they're not always. And the similarity that I always compare this with is with the proximal hamstrings. You know, if you look at everyone's proximal hamstrings, you quite often see a little sort of cleft, a little bit of fluid just next to the hamstring origin. I think it's just like this, just at the symphyseal cleft. You can see here just a tiny bit of fluid. In the right clinical context, very significant though. The other thing is pathology around the adductor muscle insertions themselves. And you can see in this patient had a complete avulsion of the adductus longus, where the arrow is here. And this is a more serious injury, for sure. And you can see in this example that there's been complete avulsion of the common aponeurosis. Okay, so I call this the inverted shark fin sign, because what you see here on the sagittal, what you should see is a black triangle. It looks like a shark's fin that's upside down, sort of shaped like this. And any loss of that jet black on all sequences shape with the common aponeurosis, that shark fin shape, is highly abnormal, okay? And you can see this very much on the sagittal obliques and the coronals. Okay, so the MRI is relatively easy as long as you get the right sequences. So as long as you communicate with the radiographer or the radiologist that you're interested in groin pain, you want those axial obliques, you need to have the small field of view images, then you'll probably get a result that matches the clinical findings, in most cases. Ultrasound is much more difficult, okay? So I've already said that cortical irregularity in athletes is often seen in in the asymptomatic athletes, particularly with these little calcifications. And you can see here, this patient had lots of little sort of enthesial calcifications here, and there was some discussion about, was this normal, was it abnormal? And it's difficult, actually, it's really difficult. And I think clinically, if you're pointing very much towards an inguinal cause of the problem, and we see this irregularity, it's very hard at that point to not put a needle in, I think, and start dry needling the enthesis, and you probably don't put so much steroid in these days, but I think you need to have a real sort of skeptical eye, I think, when you're looking at this sort of appearance, and think, well, is it really abnormal for them? But anyway, ultrasound does demonstrate the area well, and it is useful for guiding percutaneous intervention. So I'll show you that actually in most patients we use the two techniques together. So ultrasound, we've talked about the adductor-related ultrasound, now the inguinal-related ultrasound. And from this slide, what's important is that you can get a really good dynamic assessment. And you lie the patient supine, and then you stand them up, and you try some maneuvers. And in the supine athletes, you really shouldn't see a defect in the posterior wall. It's okay to see a little bit of bulging, but you shouldn't see any prolapse of preperitoneal fat. It's a little bit difficult when you stand the patient up. Again, you really shouldn't see frank peritoneal fat or gastric contents or intestinal contents coming through that deep wall. Although a little bit of bulging, actually supine is within the normal limits. So have a look for transversalis fascia bulging, have a look for inguinal ring dilatation, but make sure that you scan the patient supine and standing. Okay. And then so finally, really, this is the approach to imaging that I would advocate. And you can see that I split the patients very much like Thorberg does into two groups. Those that will benefit from ultrasound and those that will benefit, by ultrasound and MRI. Okay. And the take-home points, really, we're out of time. Take-home points are, recognise that osteitis pubis is the two most important features on the MRI, osteitis pubis and the presence of an adductor cleft, okay? Adductor cleft being the more relevant, osteitis pubis, we don't want to be squinting too hard at the screen, because it's probably normal in a 20-year-old. And also, when considering these young athletes, just remember that pubic symphyseal cortical edema is a normal finding, okay? So don't forget other causes of groin pain from the away from the symphysis, of course, the lumbar spine, the SI joints, the hamstrings, because those are all important too. And I'll pass the baton over to our orthopedic surgeon, who will concentrate mainly, I think, on the intra-articular causes of hip pain. So thank you.
continue now with the presentation from
Kaj? Ja, če hočete
Dr.
uporabljati, pa naprej klikati s tem.
concerning the indications for surgical treatment of hip impingement syndromes in sports. Okay?
Tale?
Yes.
Ni transfera.
Včasih malo štika. Samo zdaj pa ni slike.
Bom pa par gledal. Okay, thank you very much. Yes, I'm going to talk about the intra-articular causes of groin pain, in particular about hip impingement. What is actually hip impingement? We also call it femoral acetabular impingement. It is a condition where the bones of the hip are abnormally shaped, and acetabulum and the femoral head, they do not fit together because of it. They wrap against each other in flexion, and in time it causes damage to the joint. So we have actually two types of impingement. The first one is femoral type, which is caused by the abnormal shape of the femoral head, which is, as you see here, not spheric, with a bump on the anterior part of the head-neck junction, and in flexion, internal rotation, especially in flexion movement, this bump comes into the contact with the acetabular rim. And in time, this is the site where the injury starts. So the pincer type of impingement is acetabular type. We call it also pincer because this is the pincer, this instrument. And it is caused by a deep acetabulum, the acetabular overcoverage. You see here the excessive bone of the acetabulum of the socket, and this part comes into contact again in flexion movement against the femoral neck, and again in time you can have a damage right here. Let's talk about the stages. First stage, or stage 0, is actually asymptomatic stage. Athletes can have a decreased range of motion in flexion and internal rotation because of this mechanical obstacle. And I have to stress that femoral acetabular impingement is actually responsible for natural selection in some sports where extreme range of motions are necessary, for example in gymnastics or in dance. Stage 1 is already painful stage when the labrum is torn. The labrum is the structure on the rim of the acetabulum, the fibrocartilage structure, which is very important for the normal hip functioning. And you can have also chondrolabral separation and focal cartilage lesions on the anterior superior part of the acetabulum, as you can see here. This is the arthroscopic picture. You can see only part of the joint. This is the anterior superior part of the acetabulum. And in this stage, athlete would have mechanical symptoms, sharp stabbing pain in flexion, and what is typical that the passive flexion in combination with adduction and internal rotation is usually painful. This is the Fadir test as you can see how we do it clinically. In stage 2, there is already advanced osteoarthritis. If we do not treat hip impingement, it can advance in osteoarthritis. And if this is in the advanced stage, then you cannot treat this condition anymore with preservation surgery. The athlete would complain here about the dull pain already during the rest, later also at night, and a second provocative test, so-called Faber test. That's the passive flexion, abduction, and external rotation is usually painful. What about the epidemiology of the hip impingement? The prevalence of CAM impingement, this is the femoral type of impingement in asymptomatic population, is 14%, so quite a high percentage. But if we look the active athletic population, for example, male soccer players, they have even higher prevalence, higher than 50%. There is not that much science about the epidemiology of pincer, but active female soccer players can have 10 to 26% of pincer impingement. That's acetabular type of impingement. There are still questions to be answered. What percentage of asymptomatic population with hip impingement will become symptomatic in time? We do not know this. And which are those risk factors that make patients or athletes, not patients, to become symptomatic, to become patients actually? Is this the overuse, or is it acute injury? I have to also say that in most cases, in more than 50%, you have combination of femoral and acetabular type of impingement, not just a simple CAM and pincer. Let's talk about the etiology. What is known now? The recent literature has shown that it is the overuse in childhood is very important for femoral type of impingement to develop in male athletes. Why is it? Because at age 12, 13, there is a highly active bone remodeling of the femoral head-neck structure. And vigorous hip loading in flexion and external rotation can end in improper modeling and can end in aspheric femoral head. For example, you can have here, you can see here a hockey player with extreme flexion and external rotation loading during skating, and studies have shown that ice hockey players are 4 to 5 times more at risk for having CAM deformity compared to some other sports, compared to skiers. CAM deformity is also is also related to the intensity of practicing during certain age. It is now known that if athletes practice more than 3 times a week before the age of 12, they have a significant higher possibility to have CAM later on, to have aspheric femoral head, compared to those who train less than 3 times per week. I said that flexion, internal rotation, and adduction is risky to get the injury of the labrum and the cartilage. And look these goalies, how they train every day. This is extreme flexion, internal rotation, and adduction of the hip. I will just mention also two types of acetabular type of impingement, pincer type. The one is global pincer. You can see here that the socket, the acetabulum, is very deep. And you can have also focal pincer, which is caused by acetabular retroversion, the wrong version of the wrong position of the acetabulum. It is orientated on toward the dorsal of the patient. And you can have if you have a retroversion, then you have a focal overcoverage here on the anterior superior part of the joint. I will just go fast through the radiographic evaluation, which is very important. If you have patients with positive clinical signs, you have to do a complete radiographic evaluation to find the reason. I usually do 3 X-ray pictures. The one is standing AP view, which shows me here signs of focal pincer impingement retroversion, or global, very deep acetabulum. You always have to measure these angles of coverage, because sometimes everything looks normal, but if you measure these angles, you can find that some hips can be also dysplastic, but these dysplastic hips are treated completely different than impingement hips. I do also special axial view, down view, just to see how spheric is the femoral head. I always do, before the operation, I always do also MR arthrography, which is the most specific and sensitive examination to show labral injury and the status of the cartilage, which is very important to know, because we have to treat this sequelae. And I started recently to use also CT3D to understand the whole anatomy and deformity of the hip. Sometimes, as you heard before, symptoms are very atypical, and I also use sometimes injection of anesthetic into the joint just to confirm that the pain really comes from the hip. How do we treat hip impingement? Conservative treatment is not effective in long term if athlete continues to play. And it is recommended now that we do not wait too long, because otherwise this is associated with poor prognosis, even if we treat these patients. So what is the goal of surgical treatment? It is to treat the sequelae, the labral tear and the chondral lesion, and to restore normal anatomy, to treat deformity. Labrum is a very important structure of the hip, and now we know that we have to do everything to preserve this structure. So we try to fix it back on the acetabular rim, as you see here. This is the arthroscopic view, maybe for some hard to understand, but you can see that with these suture anchors we can fix this labrum back to the acetabular rim quite good. But if the labrum is very small and degenerative changed, we then just resect it to avoid further pain. We also have some possibilities to treat focal chondral lesions, microfracturing, as you know from the knee. This is the the penetrating of the subchondral bone just to make bleeding, to produce bleeding into the lesion, and it can then result in pseudo or fibrocartilage over the lesion. You can even glue the delaminated cartilage if it is in good condition. Unfortunately, there is not enough evidence that this really works in long term. And you can also use cell implantation techniques that are known from the knee, especially on the acetabular side, which is concave, and this matrix can stay on place quite good. If we have a pincer tip, then we have to resect the overcoverage. We do it with the special shaver, and for each millimeter we reduce the CE angle, which is parameter of the coverage. We reduce the CE angle for 1 degree. So 12 millimeters of trimming results in 12 degrees of decreased CE angle. Okay, I will skip it. Then on the femoral side, we do reshaping of the femoral head. This is before the injury, before the surgery. You can see the bump, aspherical shape of the femoral head. We try to do the spherical one. This is how it looks like during the operation, and you can see that we are very limited with the visualization. And at one point, surgeon can ask himself what I have done, what I have to do yet. So sometimes you can be even lost in space, and you have to control it with some kind of tool. That's why this is very demanding part of the hip arthroscopy, and there is a tendency to undercorrect sphericity of the femoral head in praxis. We use computer assistance. I just choose this that you can see more animation and to understand what we do. And from the CT scan, we do 3D reconstruction, and we simulate range of motion, inflection, internal rotation, actually in the impingement test. And the computer then calculates how much of the bone has to be removed on the femur. Then everything, the plan, is transferred to the surgical navigation system. And here is the arthroscopic view, the same as you've seen before. But we can have also here the animation, what we do, and more precise 3D visualization, where we are, what we do, how deep we are, and with this tool we are more precise. So what is the outcome of arthroscopic treatment of hip impingement? The literature shows good results, a little bit lower than 90% of patients, of athletes, can return to sport after surgery. I think this is quite a high percentage in my practice. Maybe this is a little bit lower, but I don't know. Maybe I'm not that good. Very important is that we do not treat athletes who have already osteoarthritis, because then we can expect bad result, and we should respect the labrum. We should fix it back. So young athletes are at risk to develop hip impingement, especially those who are involved in specific sports. Ice hockey, as you saw, soccer, basketball. It is, there is data that it is proven. Consider to avoid too much practice in children younger than 12 years if you want to avoid these deformities. This is really hard. We have to persuade the trainers. It is impossible. The last take-home message is that arthroscopic treatment is a choice of treatment of hip impingement syndromes, and it enables athletes to return to sport in pretty high percentage. Thank you.
Thank you, Dr. Stražar. Coming to the end of session 8, if there are any questions or comments, now is the time. Okay, if there isn't any, I will pass the chair to Dr. Klemen Stražar and Dr. Hristo Lirgis for the next session.
Naj gre za dolgo ali kratko pot. Zdaj lahko poskrbim za svojo družino, ker moje gorivo poskrbi za moj avto. Izboljšani dodatki v gorivih MOL učinkovito zmanjšujejo obloge in tako čistijo motor. Z novo generacijo goriv MOL Evo poskrbite za motor vašega vozila.
Okay, let's start with the next session, session 9, making decisions during growing problems in adolescence. And the first speaker is my colleague from the orthopedic, our orthopedic department in University Hospital Ljubljana, Professor Drobnic. He will talk about pediatric foot deformities in sports participation. Please. So it's your turn, yeah?
Thank you. Do I see my presentation up here? Yeah. Okay. So thank you for the invitation, and my duty today is to give you an overview over the deformities in foot in the sports participating children. This is a big topic, so I'm sticking to basics right now, and hope you'll get some useful information for your daily routine work, and if you have any specific details, I'll be happy to answer them at the end. So first, what bothers me in this title is the deformity. Deformity or dysmorphism or dysmorphic feature is a major abnormality which can be caused in utero, after birth, or later on in life. And when we orthopedic surgeons consider deformities, we think of it as a rigid deformity, so some severe malformation, and this is not really what we're going to talk about today. So it's better to use the term foot posture for these smaller problems. When we talk about the foot posture or the foot shape, the major the main question is what is the normal foot? You know, everyone has a bit different foot, and the definitions about the neutral foot or neutral pronations are really vague. So the idea is, I can't show you with the mark, to get the heel strike, then to get to the forefoot and push off with the toe. So this is a kind of a neutral foot, but looking at the statistics, there are only 30% of the people of us in adulthood, we have what is called a normal foot, but only 10% of the people have some problem with foot otherwise, so there is a big gray zone. So if it is not normal, then it's either flat foot, which is meaning that the medial side is going down, or it's an too high arches, so that is called a cavus foot, so the lateral side is touching the ground and the medial arch is too high. And there are several different delineation, and this is one of the easiest one, having 6 different foot types. But this is all a kind of approximation. So how do we evaluate these foot postures? The most important is, of course, clinical evaluation, but that has to be done in static and in dynamic manner. The problem is how to classify, how to evaluate the foot posture, and one very useful index that's been a lot used in the last years is foot posture index. This is a measurement, semi-quantitative scale consisting of 6 different parameters. And this is a very good tool to do some studies and to follow up our patients. The only problem with foot posture is it's a static measurement. If you want to have a dynamic one, then we can use navicular drop or other tests. So here you see the foot posture index changing through the years. So initially, the higher numbers of foot posture mean pronation, the lower numbers mean supination. So when we are young, we are more into the pronation, then we go down into supination or into the neutral, and then with the older ages, we go again more into the pronation, so the foot is flattening again. So if we want to be a more objective, then we can do footprints, which is a very old style of evaluating the foot. We can do the pressure pedobarography, either in standing or walking, or we can do motion analysis. There are several apparatuses out there, and it's really hard to compare all the data. And the last resort, which comes really when the patients come to us, to the orthopedic surgeon, is the weight-bearing radiographs. And with radiographs, they need to be done in the weight-bearing. We can measure certain angles, and then these angles would show us whether we are still in line of normality or we are going over it. So when we start talking about the foot posture and sports, the first question is the foot posture change related to sport participation, or is it the posture there by itself? The evidence that sports would somehow chisel the foot, it's really minimal. When they analyzed a big cohort of school kids in Brazil, they saw that the gender, the obesity, they were not really related to the foot posture in the kids. But on the other hand, some smaller studies show that active kids are a bit more supinated than non-active kids. But these are really small statistical numbers. When they studied adults participating in sports for a long time, they realized that runners and basketball players are more neutral, and the handball players are a bit more supinated, so a bit more higher arches. But these statistics are really low. So we can, at current, we can say that there is the link between the sports participation and the impact of the foot shape is really minimal. But of course, sports participation can cause symptomatic foot. This is the other story. When we start evaluating a foot, either cavus or flat foot, we need to delineate between the flexible deformity and the fixed or rigid deformity. And in between, there is a semi-rigid. So If there is a flexible deformity, this is really a nice flat foot, but when the patient steps up, the arch is formed again. So that means that in unloading position, it gets back to the normal. Whereas this, in cavus, this is a rigid deformity, so no matter how patient will move the leg, this deformity is remaining. The supinating deformities, the cavus, it's more rigid than the flat foot. The flat foot in the early stages, especially in the kids, is most likely to be flexible. So let's go into the cavus, into the high arched feet. The cavus, or excavatus, or cavovarus, there are different terminologies. It's usually not a foot problem, but it is a problem of higher levels. It's usually about the neuromuscular deficit, and a cavus starting very early in the childhood would, in 2/3 of the cases, mean some neurological problems behind. There are different types of cavus deformities, and it can be hindfoot, forefoot, and we can delineate between them with so-called Coleman block test. There is usually a plantar flexed first metatarsal, peroneal tibialis posterior is firing too much. There can be short gastrocnemius, low power intrinsic. So there are many combinations that would cause cavus foot. The cavus foot is problematic because it overloads the lateral part of the foot, and that can result in the stretch fracture of fifth metatarsal, peroneal ruptures, lateral ligament instability, stress fractures of the fibula. So there are many things that can be related to the cavus. You are not hearing much about the cavus, but the cavus or supinating foot is much more at risk for injuries than the flat foot. How do we treat it? Well, the insoles for the cavus need to be customized. They are usually quite high to support the first metatarsal going down, some slight lateral wedging. The problem is they cannot be commercial because every supinating foot is a bit different. So that's why also supinator type of sports equipment is really not existing, and they are mostly neutral because the pronators are much easier to treat. So when it comes to instability, you can help with exercises, braces. When it comes to pain, there is a physiotherapy, and the stress fractures, if they are present, they need to be treated accordingly. The surgery, it can be done, if it is a small cavus, then it's mostly metatarsal osteotomy or calcaneus osteotomy, lateral displacing, but in severe cases, albeit these guys don't really participate in the sports a lot. It's a big surgery on many levels. On the other hand, we have a flat foot. So the most common flat foot that you see in pediatrics is a flexible pediatric flat foot, which is not a disease. This is a normal foot. So kids are in valgus, they would look like this. But if they step on their toes, or if you do the jerk test to raise the big toe, the arch gets formed. And this is not an abnormality, and this will go away with years. You see, they were following these patients, and in 3 years, they go much more from pronation into the supination. So these guys don't need treatment. If the flat foot is symptomatic, there must be some myofascial disbalance. This needs to be treated. Only decompensated flexible flat foot, that means after the age of 12, if they don't lift the arch, then they would require some treatments, and if they are rigid. A very important issue is tight gastrocnemius. Gastrocnemius is a muscle that actually bridges 3 joints, and in a very limited amount of time when the knee is extended, you cannot dorsiflex the ankle if the gastrocnemius is tight. And in those cases, they will overload the midfoot, causing additional dynamic flat foot. So if this is the reason, it can be established by the silver scale test or the weight-bearing lounge test. There are some others. If you find there is a difference between dorsiflexion in extended and flexed knee, then calf stretches are really an important thing. Sometimes even surgical releases of gastrocnemius tightness. Hyperpronation syndrome. You'll see a lot of these images. If you have hyperpronated foot, then you'll have a headache. Well, what is the real relation in the studies? The studies have shown there is a slight correlation with medial tibial stress syndrome, with anterior knee pain, smaller amounts of back pain and hip pain as well related to the hyperpronating foot. So it doesn't mean that everyone needs treatment, but if you have a patient that is hyperpronator and comes to you with valgus, dynamic valgus, then consider correcting the foot as well. Conservative management. In those guys, pediatric, flat foot, don't use the insoles. Not necessary, only in the decompensated ones, which are very limited numbers. Do they need special orthopedic shoes? No, they don't. Do they need exercise? Exercise are beneficial in terms of symptoms, but they cannot really push your arches up high. Barefoot walking, it's nice, but it's not really changing the shape of the foot. The surgery, there are some options. The most minimal invasive arthroresis, when we put a screw into the sinus tarsi to block the pronation, quite a successful thing in kids. And also they can continue with sports without any limitations. And then if the deformities are bigger, then we go further on into the osteotomies, spring ligament reconstructions, but this is not very common to be done in such young ages. Tarsal coalitions to be mentioned. This is a rigid foot, rigid flat foot, so there are bony bridges between two bones, calcaneonavicular, talocalcaneal, and then they can cause flat foot, but that is rigid, and if you want to treat it, that would require removal of these bony bridges as well. So as for the end, deformity versus posture. So posture is more dynamic, deformity is rigid. This foot posture misalignment, there are more likely primary causes, not the consequences of the sports. We have normal posture, we have cavus or supinated or flat pronated, flexible or rigid. Cavus foot is at higher risk for sports injuries. Flat foot is linked to posterior tibial tendon deficiency, medial tibial stress syndrome, patellofemoral and hip problems. The exercise is beneficial for symptoms and function, but doesn't really change the foot posture. If there is an isolated gastrocnemius tightness, you have to do the calf stretches, and medical attention is only to symptomatic fit. So if there is a flat fit without any symptoms, just leave it alone. And there are some surgical interventions that are really good, but they are used really selectively. So thank you.
Thank you. Thank you, Matej. Please stay a little bit at the podium, and it's time for questions. If anybody has a question, please stand up. If not, I have only a short question. Is it possible to say which child will be a good, for example, long-distance runner according to the shape of the foot? Is it, can you select those foot that are better for this kind of activity?
No, you can't really, especially in the kids, because there is a changing of the foot shape through the years. The only thing that we know, if someone is supinator, so having a high arches, they have higher odds to develop stress fracture, lateral instability. But these odds are not so high that we would say, you have flat feet, you can't run.
Thank you.
Okay, let's continue to the next session. And
We have another question. Sorry.
Yes.
Is there any evidence, or according to your experience, that the calf tightness might be sometimes, or even more often, up to the soleus muscle, not the discontinuous? I mean, is there a differential calf tightness test which you do with knee extended and flex? I'm asking that because very often we see in deep squatting in athletes that they increase the flat foot position where they are completely down, going to extreme dorsal flexion with the knee flex. So any evidence about that?
So the question was whether there is a soleus tightness can be also an issue. I would say that in deep squat, there is different mechanism because it's just the overload of the foot because you're usually pushing the knees forwards. So the soleus itself, it's no really evidence that it would be directly related to the flat foot.
What's your exact indications for basic health under 16-year-old?
For PET?
Indications
For
surgery.
for surgery.
Yes.
Pes cavus in kids, surgery, when they have a lateral ankle instability and I go and repair the ligaments, they will also correct the cavus. Or if they have a peroneal tears, then I will also correct the cavus in the young ones. Sports, if they are not neurologic, that's a different story.
Okay. The next speaker is Professor Christodoulou. He is a specialist in physical medicine and rehabilitation medicine. He is professor in European University of Cyprus, and he will speak us about the patellofemoral biomechanics and dislocations.
Thank you. Thank you. Hello to everybody. I would like to thank the organizing committee for inviting me to give this lecture, this presentation, which has to do with the patellofemoral biomechanics and clinical implications. We are going to see the biomechanics of this joint, the disorders, the clinical implications, and treatment procedures. The anterior knee pain is the symptom that we have to investigate concerning this patellofemoral joint. It is a frequent pathology. Up to 25% in the general population is found. 85% is due to patellofemoral disorders, and 15% to peripatellar pathology. And we don't know exactly if the percentage affecting from the hip pathology. Here you can see the prepatellar bursitis, which is traumatic cause most of the time. And let's see now the basic biomechanics of this joint. So we see at the sagittal plane the forces that are applied to the patellofemoral joint here. We have a tension from the quadriceps and a tension from patellar tendon. So we can find this force that we call it R1 force. And it's called patellofemoral compression force, PFCF. And as the flexion is increasing, there is increasing of this force on the joint. Well, we don't have time to say more, but as it is increasing, the force is increasing. And here you can see the force applied on the femoral part of the joint. When there is a walking situation, we have the quadricep force is one body weight, and on the patellofemoral compression force is the half of the body weight. When you have stair climbing, it's increasing, and the quadriceps force is 2 body weights, and the patellofemoral compression force is increasing to 2.5 body weights. And the descending stairs is even more the force. So if we go now to the frontal plane, we can see that we have this force from the anterior superior iliac spine up to the midpoint of patella. And then we have from midpoint of patella to tibial tubercle, and then you can find the force that we call it R2 force, the resultant force. And if you go to the transversal plane, we can see both the R1 and the R2 forces, and this is the R1 and this is R2, and the resultant force is this one, and you can see if where it is localized. You can find if the patellofemoral joint is stable or unstable. So, concerning the anterior knee pain, if there is a malalignment, it can lead to subluxation or luxation. And of course, it produces femoropatellar dysfunction, which leads at the end to chondromalacia. The disturbances in patellar stabilization lead to patella malalignment, and it is a predisposition to patellofemoral dysfunction. The stabilization of the patella is due to static factors and dynamic factors. Static factors is the lateral femorocondyle more prominent than the medial condyle, the shape of the patella, the medial retinaculum. And dynamic factors is the activity of vastus medialis obliquus and the pes anserinus. The vastus medialis obliquus quadriceps is a part of the vastus medialis. Vastus medialis has two sections, the vastus medialis longus and vastus medialis obliquus. And you can see here all the musculature that has to do the quadriceps and has to do with the patellofemoral joint, and this is the vastus medialis obliquus, which usually is considering the rectus femoris. It is in an angle of 50 to 55 degrees to work properly concerning the patellofemoral joint. Now the pes anserinus, which is consisted from the tendons of the muscles of gracilis, of semitendinosus and sartorius, they increase the knee flexion and the internal rotation of the tibia and decrease the Q ankle. We will see what is the Q ankle. This is the pes anserinus here with the three muscles. And you can see here how many forces are applied to this patellofemoral joint, and we have to consider them if there is a problem, how to solve it first conservatively, and if not possible, then surgically. So you can see here, these forces here are from the lateral retinaculum. The force here is from the tensor fascial lata, and then is the force from vastus lateralis, then is the force of rectus femoris, the vastus medialis obliquus, and the medial retinaculum. And here is the pes anserinus. And finally, this one is the patellar tendon. So, by looking to all this, we can divide them to the external forces and the internal forces The patella increases the efficiency of the quadriceps muscle, giving better extensor moment arm, but patellofemoral compression force is increasing. Now for the Q ankle, that also we have to know. If we take a line from the midpoint of patella to the anterior superior iliac spine, and another one line from the midpoint of patella to the tibial tubercle, then we have here the Q ankle. Yes, which if it is increased over some degrees, then there is a pathology. We don't have time to say how much is the normal according to these studies, but let's go and see about the patellar itself and the frontal plane, the sagittal and horizontal plane that are affected. So we may have a patella that we call him alta or baja infra, higher and lower, and this is, we may have alta, higher, due to shortening of the rectus femoris after an hematoma, and lower, the baja, after operations, contractions, multiple arthroscopies and all this, they keep it lower. So at this figure you can see here is the normal place, but here is the lower and here is the higher one, which affects the function of the patellofemoral joint. Here is the same. We don't have time for explaining this. So another thing is the dysplasia of the patellofemoral joint. You can see that there is hypoplasia of the lateral femoral condyle or abnormal configuration of the patella. And this affects also the function of this joint. We measure this space, and as higher is more the problem, the pathology. We have a so-called kissing patella, which is due to increased femoral underversion or increased femoral internal torsion, which leads to increased external rotation of the tibia and increased Q ankle. You can see here a kissing patella, and there is an alignment problems. Now the increased Q ankle now is genu valgum of the tibia, increased femoral anteversion, increased femoral internal torsion, and hyperpronation activity of the foot. So the vastus medialis obliquus dysfunction is another problem. The reflex inhibition due to pain and inhibition of muscle activity due to intra-articular hydrops. If there is insufficiency of this muscle, it can reflect inhibition due to pain and atrophy secondary to disuse. Also, there are other muscular factors of the other muscles around. We don't have time to explain them. And hyperpronation, hyperlaxity of the medial retinaculum, tightened lateral retinaculum. As you can see, if we have tight lateral or loose medially, we have a malfunction of the leading to a subluxation or even luxation of. Well, sometimes you have patella hypermobility, and there is patellar subluxation, and this here is a way of examining this hypermobility of the patella. And 4 parameters play a dominant role: the shortened quadriceps muscle, an altered vastus medialis obliquus reflex response time, a decreased explosive strength, and hypermobile patella. The clinical point, of course, we said, is the anterior knee pain, which can be chronic or acute. I'm sorry, they show me that the time has ended because my presentation was for 30 minutes, but they changed the session that they put. So all these subluxations and luxation problems with the biomechanics I have shown you, they lead to problem of the and malfunction of the femoroparticular femoropatellar joint, leading finally to chondromalacia. And to diagnose a Zohlen sign is a good point, a clinical sign to find out for the problem in this joint. How to treat in conservative treatment? I mean, we have to do the pain treatment and taping for prohibit too much hyperactivity of the patella. We can do stretching and passive mobilization, muscle re-education, correction of hyperpronation. The pain treatment, the goal is effective re-education of the vastus medialis obliquus by using modalities, of course medications, non-steroid anti-inflammatory drugs, glucosamine chondroitin is in question now, physical therapy by TNS or other physical means, mechanical, intra-articular infiltrations like hyaluronic acids, braces and taping. You can see here several braces and taping. The taping, the aim is to protect the patella to go exteriorly, laterally. Okay, this is also for the taping of the area. We need 1 hour to say all this in details. And of course, the stretching and passive mobilization is very useful. Muscle re-education of the muscles of the area, correction of hyperpronation. We have to do also muscle strengthening and stretching of the muscles. Together with passive mobilization of the hamstrings, the gastrocnemius, the ITB, the passive mobilization of the patella medially. These are some icons for these stretching methods. And of course, in the conservative treatment, there is the muscle re-education. In general, the treatment we use isometric exercises for the quadriceps, vastus medialis obliquus, stretching hamstrings, tensor fascial lata, vastus lateralis, and correction of contributing factors, and open or close kinetic chain exercises according to the malalignment of the patella. And of course, we do correction of the hyperpronation, and we use also foot orthosis. And you can see here other modalities that we use. for vastus medialis and proprioceptive training. And we have to design the exercises program either as an open chain program or a closed chain program. And here are the explanation for the therapeutic open chain program and the therapeutic closed chain program. Well, if there is chondromalacia diagnosed, probably we are going for surgery, and it's not my, of course, specialty to explain you on the surgical approaches. I think that this has been presented already. Sorry for being so fast, but thank you for your attention.
Thank you very much. Are there any questions about this lecture? Okay, thank you very much.
Thanks very much.
Thank you. Now, Miha Vudičar, he's subspecialized in spine surgery. He works on University Hospital Ljubljana, actually together also with me. And he will talk about idiopathic scoliosis and athletes.
It works. Okay, thank you for the presentation. So I'm an orthopedic surgeon, but basically all I do is about spine surgery. And now my biggest thing to tackle is spinal deformity. When it comes to spinal deformity, it all starts with the adolescence idiopathic scoliosis. And when we talk about it, there's a lot to say. Now, what happens with scoliosis in athletes is sort of the point that I'm going to try to make today. So this is the syllabus. I'll try to review it fast because we're a bit late on time. So scoliosis is defined as a three-dimensional deformity of the spine. So all three dimensions, sagittal, coronal, and axial plane need to be rotated, and it has to have more than 10 degrees. If it's under 10 degrees, then we cannot talk about scoliosis. Which is really important is that when we talk about scoliosis, we need to know that it's not only a spine deformity, but also a trunk deformity. And this enables us to see the scoliosis on the Adams test, where we have the rim hump that exerts on the convexity of the scoliosis. It's also where we can measure it with a scoliometer, but that measurement is not very correct. It's only used for screening. If we want to correctly measure a scoliosis, then we need to measure the Cobb angle, and that tells us how big the scoliosis is. And now, then we can classify it. This is the Lenke classification for scoliosis, which basically tells us where the curves are and how big they are, whether they are structural or non-structural. Then they tell us what happens with the coronal balance of the lumbar spine, and it tells us what happens with the sagittal plane of the spine. This is very useful for surgery, but not as useful for athletes when we are discussing whether they should train in certain programs or not. So when we discuss about athletes, we can just say we divide them into athletes with mild scoliosis, moderate scoliosis, and severe scoliosis. So this would be a case of mild scoliosis, which is 16 degrees, and this would be moderate. We can see it's a measurement of 32 and 30, a double scoliosis. And this is a severe scoliosis. This one's about 65 degrees. So I intentionally put these slides under evidence-based indications because what I want to stress is that there's no concrete evidence. So there are no widely accepted guidelines. The Germans have published 2 papers within the last 30 years with recommendations, not guidelines, but recommendations on sport activities and participations in sports for the patients with scoliosis. However, I'll try to sum it up because I've seen a lot of papers doing this presentation. So, which is really important is that all the papers are saying that conditioning and physiological benefits come from sports when we talk about patients with scoliosis. Then some sporting activities were also suggested to promote scoliosis, for example, ballet and gymnastics. But once more, there's a matter of chicken and the egg. So we don't know whether patients with scoliosis are more prone to go into these sports, or is it the other way around? Basically, there is no evidence that would correlate the curve reduction with sports. So there's no exercise that would reduce the curvature of the spine. However, it helps with other things. So when we talk about mild scoliosis, so under 25 degrees, there's no special treatment for this. So we only observe these patients. We make an X-ray every few months or every half a year to see whether it progresses. These patients are actually suggested sports and also scoliosis-specific exercises. There is no data that would advocate for any adaptations or restrictions in competitive sports. That means that if you have an athlete that has a scoliosis under 25 degrees, treat him as if he's normal. Then when we have moderate scoliosis, so between 25 and 45 degrees, then we start bracing them. Now, the braces, they used to be very hard, big, very much unlikely to be worn by the patients because they had a lot of problems with it. With the onset of new materials, especially carbon, these braces have become very patient-friendly. So they tend to wear them more strictly. And as we can see here, they don't change sport habit of patients. Not athletes, but patients. So we sort of have to divide here that patients who are athletes are different than patients who are not. Now, certain papers suggest that avoidance of competitive sports would be beneficial in these patients. But we need to ask ourselves why. If we take a look at some recent papers, they show that worse physical fitness in overall population is for the patients with scoliosis compared to healthy controls. That means that patients who have scoliosis, they already start with a lesser background. They have less physical capability. So why would we avoid sports for them? Now, the question is answered within these papers. And basically what happens is that when we put these patients into sports, they have better physical activity. When they do better physical activity, they exhibit better self-awareness, so it's also very good psychologically for them and a psychological profile. So I would say, why not put them into competitive sports? If they can do the sport, there is basically no advocation against it not to do a competitive sport. We can see here's the paper that discusses the egg and the chicken theory that I was talking about before, what this paper is saying is that when you have patients with scoliosis, they are more prone to have joint laxity, and they will be more successful, for instance, in gymnastics or ballet. So it's the other way, it should be the other way around, so that more patients with scoliosis would choose sports they are good in, and that would be gymnastics, and not gymnastics would cause scoliosis. Now, when we go to the severe group of the scoliosis, these are the patients or athletes who need surgery. This is also the most studied group because they're well followed, and well, doctors have a lot of influence on what they do. This is the patient that was operated, fixated, and basically now she's straight. But does that enable sports? So if I start with the goals of traditional surgery, basically the goals are to have firm fixation of the spine, to correct as much as we can in all three planes, and to promote spinal fusion. That means that the spine becomes fixed and it won't move anymore, so that the deformity won't come back. Basically, in the past years, there's another option. It's called vertebral body tethering, which is basically a reversible epiphysiodesis. This basically means this. So if we have a deformity, then we can put in screws into the spine and connect them with a tether. And what we do with this is that we promote spinal growth on this side, and this promotes spinal growth on the other side, which means that when the kids are growing, then the spine grows on this side and the deformity becomes lesser, which is a very sort of advantage of this second type of surgery, is that the spine itself becomes flexible or stays flexible. So what happens after surgery, as in terms to return to sports? It's relatively fast. So within 12 months after surgery, most patients can do basically everything they've done before, with the exception that the lower we go with the fixation, the lesser they're able to do everything the same than they did before. So if we go up to T11 to TH11, then basically there are no obstacles. If we go down to the lumbar spine, then the flexibility of the lumbar spine reduces, and also the flexibility of the patients reduces. So generally, after surgery, by 3 months, patients already go to school. They can do bending, they can carry their backpacks in more than a half, and by 6 months, they already return to non-contact sports, a lot of them also to contact sports. After 1 year, we can see that about from 50 to 80% return to sport at the same level. These are the patients that are fused to the thoracic spine. The patients that are fused to the lumbar spine or the lower lumbar spine, they can't do it because they have no flexibility. Now we can see that this is the tether. We can see the flexibility is completely restored, and this patient has absolutely no problems doing her sport. This is the selected fusion, so it's ended at L1, and this patient also has more or less no problem during her sport. This goes the same. However, this goes down to L4, and for this type of patients, we don't have photos like that. So it's mostly how we see where it happens. Now again, this is the only paper that I was able to find in PubMed, and it says that even a silver medal winner in one of the martial arts was fused from T3 to T11. So elite sports can be done as well after surgery. Now to conclude, I can say that sports or exercise are recommended for patients with idiopathic scoliosis. Elite sports are a possibility even after surgery. Mild scoliosis should be disregarded, and patients already start with a lesser degree of sports, so we need to encourage them to go into sports. Return to sports is, of course, possible after surgery. Thank you.
Thank you, Miha, for a very clear presentation. Are there any questions?
Guess not. Thank you.
No questions, thank you. So, coffee break, yes. We close this session.
Naj gre za dolgo ali kratko pot. Zdaj lahko poskrbim za svojo družino, ker moje gorivo poskrbi za moj avto. Izboljšani dodatki v gorivih MOL učinkovito zmanjšujejo obloge in tako čistijo motor. Z novo generacijo goriv MOL Evo poskrbite za motor vašega vozila.
I'm really glad to can introduce Professor Bülent Ülker. He's a specialist in sports medicine and currently a full-time professor at the Ankara University Faculty of Medicine. Bülent, I'd like to introduce you, and your speech is the clinical biomechanics. Are we able to prevent injuries at the examination room? Please.
Thank you. Thank you very much, Mr. Chairman, and dear participants. I would like to thank, first of all, to organization committee for this kind invitation. And I will just briefly talk about the clinical biomechanics. Well, the topic is, are we able to prevent injuries at the examination room? I just want to remind you some simple and very basic rules about the examination, and also I would like to share with you some papers and some thoughts on clinical biomechanics, the practical usage of clinical biomechanics. Well, first of all, let's begin with the very simple and basic thing. And I would like to ask you, what is the most important part of a physical examination? Of course, the answer is to follow the medical examination rules. To me, it's just like that. And the parts of it is just listening to our patient and looking at the patient and touching our patients. So it's valid for, of course, in the athlete examination. So the most important part maybe is the medical history taking, and we have to investigate thoroughly the injury mechanism first of all, and we may need for this mechanism investigation the observations of the patient or athlete and the parents and family, of course observations of the coach and the teammates. And we have to just give up this very bad mistake, because I commonly see that the unilateral examination is sometimes practicing in the clinics because of the lack of time. Sometimes they say so, but it's completely a mistake, because we can miss many things if we cannot examine the patients bilaterally and symmetrically. So we have to just begin with the whole body inspection in front and the back view. And just because to find out any malalignments, for example, genivarus or valgus and calcaneal valgus, for example, and scoliosis or kyphoscoliosis can be easily detected by this simple inspection. And we have to, of course, statically examine, inspect the upper body and lower body together to see the alignment. And of course, we should also examine dynamically the alignment of the body and extremities. So we have to check also the walking pattern of the athlete from the front side and the back side, of course. And we have to check the leg length to see if there is any discrepancy present or not. And we may also measure the Q angle of the athletes at the examination room. And if you have a simple or sometimes maybe complicated or complex podoscopes, and you can just take the footprints of the feet of the athletes, or you may just have a more sophisticated device and you can just see the loading pattern of the soles as well. And of course, we should also examine the soles of the shoes, because the wearing pattern of the soles of course, give us too much information about the loading pattern of the athlete. And coming back to definition, biomechanics is defined as a study of the mechanics of a living body, especially of the forces exerted by muscles and gravity on the skeletal structure. And when we look at clinical biomechanics, it is defined as the evaluation of the evidences associated with the biomechanical factors leading to injuries and management of biomechanical abnormalities which are detected during physical examinations and, of course, relevant testing techniques, procedures. When I did a PubMed search recently, just 2 days ago, and I put the keywords of clinical biomechanics and sports medicine, and I found that there are 1,193 articles, and most of them have been published in the last 5 years. So it's rather a common, a new research area, actually, we can say that. And I put the keywords of clinical biomechanics and injury prevention together, and I found only 399 articles, and more than half of the articles have been published in the last 5 years. A recent paper from Dingenen and his colleagues, the assessment of movement health in clinical practice, a multidimensional perspective, they have just mentioned the very famous aphorism of Hippocrates, movement is life. So, and they suggested a movement evaluation model to obtain a measurable movement outcome. So we have a model of examination to obtain a measurable and maybe enough data giving outcomes to collect and to publish papers and evidences. I would like to give some sport-specific examples. For example, in cycling, if there is a valgus movement of the knee, it may induce some knee injuries, it's obvious. So we have to check and try to correct the alignment of the hip, knee, and ankle to protect the cyclist from injuries. It's also valid for patellofemoral joint, because if the saddle is adjusted just to have a knee extension of up to 30 to 35 degrees, it is better to protect the patellofemoral joint from the injuries. And it's also valid for the upper extremity or the trunk, let's say. So there's usually an even flexion of the upper body. And if there are some painful conditions, especially in the back, in the lumbar spine, for example, then the alignment of the spine is changed just to maybe invite some more complicated injuries. So we have to just check if there is any malalignment or movement discrepancy in the spine as well. And it's valid for rowing as well. And during the catching position, for example, usually we are expecting an evenly distributed load on the spine. But if there is any problem at the back or hip, knee, or ankle joints, then the movement pattern can change and can lead to more injuries. So it's also well for the finishing position in rowing as well. So we are expecting a neutral spine in the finishing position, but if there is a loss of this neutrality, so it can just lead to some more injuries in the especially back of the rowers. So it's also, when we talk about the swimming patterns, we can also check the phases of the stroke of the swimmers. So if there is any difference, and if there's any discrepancy in the swimming patterns, that may induce, for example, impingement syndrome on the shoulders of the swimmers. So we have to check, and if there is any discrepancy, we have to just give information to coaches and the swimmers to just correct these improper movements. And also it's valid for, of course, the smashing of the volleyball players. And of course, tennis is a very complicated sport, and many joints and body places are prone to injuries. So the mechanical property is very important to just protect the tennis players from injuries. Well, I would like to share with you some papers as well. And a paper from Mugele and the colleagues, this is General versus Sport-Specific Injury Prevention Programs in Athletes. They made a systematic review on the effect on injury rates. And they just searched for the injury prevention programs for the athletes, a sport-specific injury program, and for the non-athletes, a general prevention program. And they found that, concluded that in this paper, that the general and mixed programs positively affect the injury rates, and sport-specific programs are really uninvestigated for the time being. And investigating the true effectiveness of injury prevention programs is a potential avenue for the future research. So it's open to really making research, especially evidence-based research. And another paper from Pollard and her colleagues, it was about ACL injury prevention training, which is resulting in modification of hip and knee mechanics and during a drop and landing task. And they just thought that participation in an ACL injury prevention training program will decrease the reliance on the knee extensor muscles, and they have found that this has improved use of the hip extensor muscles, and which may explain, of course, the protective effect of this type of training program on ACL injury. And another paper, which is just asking the kinematic and neuromuscular relationships between lower extremity clinical movement assessments. And they just said that jump landings and single leg squats place different demands on the body and necessitate the different kinematic and EMG patterns. So they concluded that the clinicians should therefore use multiple assessments to identify the aberrant movement and neuromuscular control patterns so that comprehensive interventions can be implemented. And another paper from Thompson and her colleagues was investigating the biomechanical effects of an injury prevention program in pre-adolescent female soccer athletes. So they gave intervention, they gave the FMARC 11 plus program to the intervention group for 15 in-season sessions, 2 times per week. And they found that the FMARC 11 plus program may be effective in improving some risk factors for an ACL injury during a double leg jump in pre-adolescent athletes, and most notably by reducing the peak knee valgus moment. As you can see here, they just corrected the valgus moment by this program. And another paper from Hewitt and his colleagues, they just used the Van Mechelen method for the injury prevention, and they found that the modifiable factors, the biomechanical and neuromuscular factors, related to injury mechanisms likely provide the best opportunity for intervention strategies aimed to decrease the risk of ACL injury, and particularly, of course, in female athletes. And another paper from Hewitt and Bates, they thought that preventive medicine concepts can be applied to non-contact musculoskeletal injuries to reduce the economic burden of sports medicine treatments and enhance the long-term health of athletes. And they made a literature review, and they concluded that the widespread implementation of preventive biomechanics concepts could profoundly affect the field of sports medicine with a minimum of initial investment. So the protection of the athletes, the preventing the injuries, actually is not a very expensive thing, and we just need some simple interventions, maybe just to prevent the main injuries of the athletes. So in conclusion, a biomechanical evaluation is a very important part of a clinical examination, and the simplest and the most important point of this evaluation at the examination room is to make a careful inspection, and preventive medicine reduces the economic burden of sports medicine treatments and enhance the long-term health of athletes with a minimum of initial investment. Thank you for your participation and your attention.
Thank you, Bülent, for the really very interesting topic. We have time for 2 questions. Do you use a functional movement screen? This is a device of the Americans.
Mm-hmm. Yeah, yes.
Yes.
I didn't use, I don't use it, but
okay.
Yeah, I know about it.
Okay. Thank you.
Thank you very much.
The next speaker is Nec Šarabon of Slovenia. I hope my pronunciation is correct. And I think it's also a very, very interesting topic, complex nature of functional body asymmetries, context of testing and injury prevention. And he's the Dean of the Faculty of Health Science, University of Primorska. Thank you. It is so...
Hello, everyone. I just wanted to help the professor because he has so tiny text on the paper. It's difficult to read. But the pronunciation of my second name was perfect for non-Slovenian speakers. Okay, so I think my presentation might link very well to the previous presenter. And advance it a little bit into the context of lateral and also other kinds of asymmetries or better muscle imbalances and balances. So this is the context I would like to guide you through during my presentation. So what is actually the functional movement? We are very often mentioning it, but how to define it? What is behind it and what we can do to make it function more functionally and avoid dysfunctional motions. Asymmetries in the context of flexibility, mobility, strength, power, stability and balance. There are many phases of potential disbalances. And asymmetries, what do we know today about injury risk and return to play guidelines in this context? what is known, and our clinical observations as groundstones for our plan for the next 3-year research project on the field. I would define functional movement as something that has 3 main pillars, as already mentioned: strength and power, stability and balance, and flexibility or mobility. But nevertheless, they are all linked, or must be nicely linked, with something we call coordination of the movement. This leads optimally to effective and at the same time safe movement. This is what I would call functional movement. And it's a nice interplay of stability and mobility, and very often a lack of, especially stability of certain segments, can result in dysfunctional integral motion, meaning the multi-joint movement tasks, especially when they are done and performed under dynamic conditions. Based on joint-by-joint theory, we can very often see that loss of either mobility or stability of some of the segments that play an important role in the integral function might lead to compensatory situations and dysfunctional movement patterns. When I say asymmetries, you probably first think of so-called lateral asymmetries, comparing left and right side, and predominantly research is out there on the field of strength. Strength tested single joint predominantly, and left-to-right differences are the most studied field for lower extremities, especially concerning knee joint muscles. However, as already said, imbalance in range of motion, counter motion of flexion, extension, or other movements in the selected joint. Then agonist-antagonist balances of a certain joint, and left-to-right differences. Then global asymmetries. Very often we jump to conclusions that, for example, losing the alignment in frontal plane of the lower extremity in case of asymmetric stances or actions like single leg landing, change of direction, and similar, we link them positive Trendelenburg test that the subject needs to strengthen a weak link in the kinetic chain, like hip abductors or something like that. But as we will see later on, there is no evidence whatsoever that such local approach could have a good foundation to improve, to always, or in majority of cases, improve the situation. So, local strength and power asymmetries. We have some cutoff points, what is safer and what less safe, and what is suggested to be achieved by an athlete or not. 3:2 ratio for quadriceps hamstring strength ability, but this holds true only for isometric and slow concentric conditions. If we increase the velocity, the angular velocity of the isokinetic machine, when we will go over 120 degrees per second and even higher up to 300, what you can find in the literature, this ratio should go up to 1:1. So again, caution about such conclusions is really important. Then for flexion extension of the trunk, not more than 20% of stronger trunk extensors is something that is considered safe, and there are many proofs about that regarding the idiopathic chronic low back pain. Then left to right difference, there is a nice consistency between 8 and 12% of difference in the strength field, but consensus around 10% difference is something that is taken for granted. Dorsal plantar flexion, 50%, but the biggest range of the proposed ratio is for internal-external rotation for the safety of the glenohumeral joint. Something similar, but with much less data, holds true for vertical jump outcome measures. Postural stability, very often measured in single leg quiet stance tasks in order to compare left to right, but this is sometimes far away from the real situation athletes experience every day. New technique of single leg drop landing has been proposed and more published, introducing so-called stability indexes and time to stabilization indexes in 3 directions: vertical, medial, lateral, and anterior, posterior. And these stability indexes correlate pretty nicely with frontal plane, especially kinematics, that are mirrored in valgus moments and valgus position regarding the kinematics. The professor before me already mentioned some of the pretty common detrimental injury mechanisms for acute injuries of the lower extremity, but even more for the chronic overuse syndromes. So the combination of adduction of the hip, internal rotation, valgus position of the knee, and losing the good active position or of the foot complex is something that is pretty common. But this can happen also because of the running technique, not for structural reasons. How to, using this inspection alone, we can see whether the engine is not strong enough of this athlete or the driver is not sophisticated. So if we ask the patient or the subject to try perform it optimally, what we explained beforehand to him, and he or she is able to correct it properly, then the engine is strong enough. And very often is this the case in our observations. So the informational type of training or kinesiotherapy or approach, learning the technique and not only making the muscles stronger is what matters, and we have more and more evidence out there. Asymmetries, so we have proofs to some of the performance correlates. Injury risks, already mentioned some of the cases. 12% contralateral asymmetry in hamstring strength in injured Australian football players, and nicely balanced left to right in hamstring strength in non-injured counterparts. Soccer players, hamstring collateral asymmetry, more than 15% predispose them to injuries of hamstrings as well as the knee complex in general. FMS score that has already been mentioned nicely, scores, cumulative scores, left to right, are not sensitive and do not have any predictive value. However, the studies taking a deeper insight into separate scores, for example, Y balance test as a part of it, or single leg rise test, amplitude, and so on, they have been proven to have nice predictive value and do correlate with the susceptibility to some of the injuries. Rehabilitation and return to play, 10% criterion on strength and power left to right asymmetry as return to play guideline. Post-ACL injury, decreased function in case of quadriceps asymmetry. Already mentioned some of the nice studies, how important it is that we re-educate the use of hip flexion and lessen the loading of the knee in landing, eccentric conditions, change of direction when we do rehabilitate and prepare an athlete for the return to play. Quadriceps and hamstring strength, greater than 90% of the uninvolved leg as a return to play criteria, as I already mentioned. If we go deeper into some sports and sport disciplines, there are sparse evidence on what we know today to do better practice in prevention as well as rehabilitation, especially late rehabilitation. Among the European sports, probably volleyball, handball, and soccer are most studied. There are some of the other studies that might be relevant, especially in ballet dancers, regarding the lower extremity range of motion problematics and the compensatory role of the locked knee external rotation when we want to reach high amplitudes of the lower extremity external rotation. So systematic reviews show that previous injury, fatigue, and muscle imbalance are the most important risk factors for the new injuries to occur. And we always ask ourselves whether this previous injury is the strongest predictor because we didn't do our job well. So what we can do is external support, re-education of the subject, muscle imbalance diminishment, and probably some other things which we can affect, which we can have control at least partly upon. Here is a summary table of what we do know about local and global asymmetries behind the acute and chronic injuries in sports. Since this is just a well-referenced table that summarizes more or less what I said before, and I'm limited in time, I would proceed from here to leave some time for discussion. Additional motivation for our project, it was some of the observational pilot studies we carried out with using very complex test battery encompassing strength, rate of force development, power, dynamic and static stability or balance, as well as some of anthropometrical measurements and change of direction. And it was just to our confirmation that we can have very, very different cases, very different examples. For example, this sprinter didn't have any obvious local strength asymmetries going hand in hand with high intensity and fatigued conditions vertical jumps, such as last 3 jumps during 30 seconds Bosco all-out test vertical jumping. Asymmetries, but not with lower forces vertical jumps. I mean, this correlation and this hand-in-hand behavior was with the lateral asymmetries were present in high forces vertical jump and fatigued conditions vertical jumps, but not in squat jumps where they experience much lower forces. So the knee extension MVC, here is the mistake, knee flexion MVC, and hip extension, they were mirrored in the complex asymmetries of the vertical jumps. No other weak links in range of motion or instability could be connected, in this case, to the counter movement jump and repetitive counter movement jump. 2 other examples, for example, the ballet dancer, weight-bearing asymmetry, so-called weight-bearing asymmetry in upright stance, semi-squat and full squat position measured by force plates. We can see here one of typical behaviors that no asymmetry, since always when it's lower than 8% we consider it symmetrical, increasing towards semi-squat position and even more in full squat position. And this goes nicely with asymmetries in passive range of motion. And this is very often, so only in post-surgical subjects or neurological subjects, you will find behind the weight-bearing asymmetry strength of lower extremity extensors asymmetry as the reason behind it. Much more often, the limitation of internal rotation or flexion that is different on one and the other side can be behind it. What else could be behind it? If this behavior would be vice versa, then the first thing we would think of is differences in functional leg length. Because the passive geometrical structure while doing upright standing will result in weight-bearing asymmetry, but will disappear with transition into semi-squat and squat by getting more degrees of freedom to adjust. This case volleyball player, an example of demanding dynamic lateral asymmetry in single leg drop landing and going hand in hand in single leg stance, going nicely hand in hand with hip maximal voluntary contraction force and ankle maximal voluntary contraction forces. To summarize, asymmetries are prevalent in various sports. Certain asymmetries are recognized as risk factors and for sustaining an injury, but also we do have some proofs for correlations with the ability, motor abilities and function. The questions that are, in my opinion, relevant and need to be answered are different types of asymmetries related between each other. Can a local asymmetry induce a global asymmetry or vice versa? Which motor abilities and how specific aspects of each ability are the strongest predictors of injuries? And is it possible to eliminate body asymmetries, and what types of interventions are most effective? If you think about the last point, we don't know much about it. So we just have anecdotal guidelines, perform additional set of the exercise on the other side. I don't know, do more repetitions, use higher intensities of your load, and things like that. But there is not a single proof in scientific literature what approach we should use to get rid of them. The most is out there for post-ACL surgery, training and strength of quadriceps, potentially strength of hamstring muscles, but not much more than that. This is our 3-year project that started just this August and will last for 3 years. We have the main columns of the project, the main lines of the project is this one and this one. This one is dedicated to cross-sectional study, 200 athletes from 3 sport groups. One sport group is soccer and basketball. One sport group is tennis, squash, and badminton, as cases of non-cyclic but predominantly asymmetrical in movement structure. And the third is triathlon and long-distance runners. At the same time, using this pretty complex test battery that takes about 3 hours for 8 subjects, we will acquire retrospectively for 12 months the chronic and acute injuries as well as training history. And starting from there on, we will for 12 months prospectively gather prospective data on injuries that are acute or chronic overuse type. The second part that also actually already started is the part on optimization and finding out what the intervention strategies could be done in athletes that exhibited major asymmetries, as well as on ACL, anterior knee pain not mentioned here, and chronic low back pain athletes.
Please come to the end.
Yeah. I will skip this slide and just a reminder that simply local interventions, decision making, whether it does improve the multi-joint asymmetry, and this is the question we would like to answer in long term. Here I would like to stop. Thank you for your attention. I would like to acknowledge the financial support by the national agency, and here are the partners of the project. Thank you.
Thank you for the excellent overview. According to time, we couldn't discuss, so I want to introduce the next is Olivera Knesević. Dr. Olivera Knesević is a lecturer at the University of Belgrade,
Yes.
Faculty of Sports and Physical Education, and her main research areas are muscle function, ACL injury, and rehabilitation and sport biomechanics.
Yes,
Please.
exactly. Yeah, I'm also a research associate at the University of Belgrade Institute for Medical Research, my primary affiliation, and of course, as I was introduced as a lecturer at the Faculty of Sport and Physical Education, with whom, with their research team, I'm closely collaborating with for many years, and the research that I'm going to show you here, well, it's a review of a number of published studies. It has been done in collaboration with them. Oh, okay.
So I think now we should, from the organizer, we should have a break because of
Oh, really? Now?
An energy shot.
Are we energy shot?
Yes.
Oh, it's an energy shot then.
What's about the
I was
music?
hoping it's going to be an exercise, but, well, yeah, then it's an energy shot. Go ahead. Huh?
What's about the music?
Naj gre za dolgo ali kratko pot. Zdaj lahko poskrbim za svojo družino, ker moje gorivo poskrbi za moj avto. Izboljšani dodatki v gorivih MOL učinkovito zmanjšujejo obloge in tako čistijo motor. Z novo generacijo goriv MOL Evo poskrbite za motor vašega vozila.
Oh, no. If I knew you were going to do that, I would put another clothes. Well, a big thank you to the very enthusiastic team for warming us up for my talk, because it is leaning a little bit to the previous talk that Professor Charbon gave. It is about the assessment of some of the motor abilities. And I'm hoping, yeah, there it is. So it is about the assessment of muscle mechanical capacities as the part of motor abilities. A quick outline. First, I will just remind you of those. There are some who know, but maybe there are some who need reminder about the classical force-velocity relationship of the isolated muscles and individual muscle groups. Then I will make a review of the series of, it's only a part of the recently published studies of the research group that I have mentioned already on the properties of the force-velocity relationship on functional multi-joint movements, and of the possibility to model such relationship using only two distinctive loads. And at the end, of course, we have some implications for the practical work as well as for future research involving, also including some of the unresolved questions. Before I start with the force-velocity relationship, just a quick reminder of what mechanical muscle capacities are. Most of you know, and it has been already mentioned, the force, velocity, and the power. I could say those are the physical sizes that falls under the mechanical muscle capacities. Force is usually used to evaluate strength as the ability of the muscles and our system to exert force under the conditions of very heavy loads or in isometric conditions. Velocity, we measure velocity to evaluate speed, and it's usually related to movements against very light loads or in unloaded conditions. And we have the power, both as the physical size and as well as the motor ability. It largely depends on the previous two, on the force velocity. We could say it's a product of the force and velocity. And when we talk about the power, in the most general way, we can say the power is produced under moderate loads at, let's say, high velocities. These abilities, the abilities that are behind these capacities, to be precise, are usually tested under a single predefined movement condition that results in a single outcome. To assess the maximum capacities, this is the most usual way we can do it. And since now you know what I'm talking about when I'm saying force-velocity relationship, we can go on with the classical view of the force-velocity relationship. As most of you know, the slower a skeletal muscle shortens, the greater the force it can generate during contraction and vice versa. And this is the fundamental principle of skeletal muscle physiology that was derived based on Hill's groundbreaking studies on isolated frog muscles from back from the 1920s and 1930s. And it originally served to develop theories of the mechanisms of skeletal muscle contraction. However, nowadays, the shape of this relationship has important implications for different aspects of muscle physiology, sports science, including sports training, sports biomechanics, clinical biomechanics, and what I like to say on top of it, biomedical engineering, because it helps engineers develop prostheses and other motion assistive devices. Force velocity curve is typically evaluated by measuring force exerted at different active shortening or lengthening velocities, or by measuring velocities produced during movement against different types, different auxotonic or isotonic forces. And then a mathematical function is fitted through the collected force and velocity points, and then using the presented equation, different performance outcome parameters could be either directly derived or through the extrapolation. Some of those parameters include F0, which you may see on the right part of the equation, which refers to the maximum isometric force. the relation between the force and velocity, as you could have seen, is hyperbolic, and it is best described by rectangular hyperbola. And that means that for the same level of neural excitation, the increase in the contraction velocity leads to decrease in force in a nonlinear fashion. And you can see that we can not only derive the F0 or the maximum isometric force, but also Vmax, or sometimes referred to as V0, which would be a maximum contraction velocity. Also, since the force and the velocity together give the power, we can also theoretically assess the maximum power. Being the product of these two sizes, the relationship between the power and velocity is also of a complex nature, and as you may see, it is skewed towards lower velocities with the maximum power or the peak power reached at approximately 1/3 of the shortening velocity. And there are a number of studies that have supported these first findings, that the force velocity and consequently power velocity relationships of the isolated muscles or individual muscle groups are hyperbolic. However, due to this relative complexity of both relationships, this limits the accuracy not only of their assessment in the functional multi-joint movements, but also their application in various modeling and optimization procedures, as well as in designing training and rehabilitation interventions. Why is this important, and why am I, underlining this? Because this raises at least two important questions. One would be, is it possible that the force-velocity relationship of multi-joint movements, which we refer usually as the functional movements, is different than the one that has been observed from the isolated muscles? If so, is it possible that such relationship is even task-specific? We will shortly see. Modeling of the force-velocity relationship in vivo, linear force-velocity relationship of functional multi-joint movements is important because it could help us distinguish between the maximal force, velocity, and power output outcomes within a single trial. As I said at the beginning, if you recall, these capacities, maximum capacities, are usually tested under a single predefined condition that results in a single outcome. Well, modeling of the force-velocity relationship could not only enable us to distinguish between the maximum isometric force and the maximum velocity, but also the power output. And as you may see here, unlike in the classical model, where the maximum power is reached at approximately, like I said, 1/3 of the maximum shortening velocity, we have the maximum power in multi-joint movements reached at approximately a half of the maximum isometric force and half of a maximum movement velocity. And there have been a number of studies published so far, starting from the 1980s, showing that the force velocity and power velocity of the multi-joint movements could be relatively strong and approximately linear. And in recent years, there have been investigations of the in vivo force-velocity relationship in an attempt to describe muscle function in complex tasks in elite sports, including cycling, a number of studies including cycling, then leg muscle actions in a closed kinetic chain, as well as upper body muscles in a closed kinetic chain, either as a bench press or a bench press throw, even the sport-specific movements like overarm throwing, vertical jumps, different types of vertical jumps. You will see some results, and Samozino and his group investigated the possibility to model force-velocity relationship in sprinting. There have been attempts also to investigate the force-velocity relationship in activities of daily living in older adults, including chair rising ability and the gait. However, I'm going to keep this review on what I would say research group that I belong to, or my research group, did in the previous years. Just a quick reminder of how it I can say all start, but this is one of the first studies that have shown that the force velocity relationship of the multi-joint movements could be different than the classical one. I would say that everything started back in 2013. The research interest into the force-velocity relationship at the research center of the Faculty of Sport Physical Education, with the guidance of Professor Jaric from University of Delaware, we investigated a number of multi-joint tasks, and somehow it was all circled up into the project that was later named the evaluation of the two-point method for quick assessment of the mechanical muscle capacities. One of the first studies that investigated the properties of the force-velocity relationship of multi-joint movements was performed on maximum vertical jumps. For that purpose, there was a custom setup that enabled to set the loads against the jumps were performed, and both maximum and average force values were recorded. And as you may see from the graph, regardless of the jump type, and we have three jump types: squat jump, counter movement jump, and counter movement jump with the arm swing, and regardless whether the, oh, I have the pointer, great. And it's not, oh, it's working. Regardless of the jump type and regardless of the variable type, whether maximum or averaged force and velocity data were used, the relationship appears to be strong and approximately linear. In addition, squat jump and counter movement jump, it seems that the force-velocity relationship or the parameters of such relationship could be sensitive enough to distinguish between the groups of participants of different activity level. Those who were training strength, only physically active, regularly physically active participants, and sedentary group of subjects. You may see the profiles are different. Another study, I would say another, it was 2 minutes. I was informed that I have 2 minutes, but I hope I will have a little bit more than 2 minutes because of the refreshment. Yeah, okay. It is the upper body movement, the force-velocity relationship for the bench press, and the bench press stroke in order to investigate the reliability and validity of the parameters of the force-velocity relationship. You can see here the traces of the force, velocity, and the power over the time, and the results revealed acceptable reliability of the force-velocity parameters and low to high validity with respect to a field test, which is a medicine ball throw test. But beforehand, you can see that also force-velocity relationship appeared to be approximately linear and strong, regardless whether the maximum or the average variables were used, and the power-velocity relationship appeared to be hyperbolic. One step ahead, there was a training study, interventional 8-week study. A bench press throw movement was involved, and we had 4 groups of subjects. Of course, one group was a control, and 3 groups were, the subjects were divided into 3 groups, each group training against an isolated component of the load. Weight plus inertia is a conventional weight plates. They have, such load has 2 components, weight and inertia, and we were able, using long stretched rubber bands, to isolate just either weight or either inertia component of the load. And the results have shown that, as you may see at the pretest, the force-velocity profiles of 3 groups were similar, but in the pretest, you can see that the force-velocity changed, the force-velocity profile changed in a way that it shows the specificity effects of the training and the load that was applied in the training groups. And the next step, somehow logical, to compare to try to generalize the force velocity parameters against, among the lower limb and upper limb movements. Lower limb, we had the squat jump and cycling, upper limb, bench press throw, and bench pull or reverse pull. So the results, again, show that the force velocity relationship appeared to be relatively strong and linear. However, the possibility to make generalization of the force velocity parameters across and among the different tasks was low. So this speaks in favor of one of the questions: is it task specific? It seems very likely that it is task specific. And something a little bit different. It is not a multi-joint movement. We can say also it's not a functional, but it is something that is really often really often applied in the assessment of asymmetries and functional strength following rehabilitation. We assess the quadriceps isokinetic force at we can say over a large, wide range of angular velocities, and previous studies have shown that the isokinetic force-velocity relationship is hyperbolic. However, if you exclude the F0 or the maximum isometric force, then the force-velocity relationship, as it has been shown by the previous studies too, appear to be linear. And here again, we use the maximum values and the average values of the force-velocity data, and the results are showing the same. It could be linear. And here are some of the main conclusions. So we have parameters that are reliable, valid, and that are sensitive, and it suggests that modeling of the force-velocity relationship could be used in the assessment of the strength, power, and velocity producing capacities of the multi-joint movements. However, we have several problems. This procedure is time-consuming because it considers testing force and velocity against a number of loads, 7 to 9 usually. It needs regression modeling, and of course it might lead to fatigue. So we might have a solution also to test the force-velocity relationship against only 2 distinctive loads, to use only 2 points, either 2 velocities if we are using isokinetic testing, or to use only 2 loads if we are using the isotonic forces. And just a quick review of only 2 studies out of many. Again, quadriceps isokinetic force. You can see the model, the full line, where we used 5 isokinetic velocities, and the black full squares indicate to the only 2 points most often applied in the assessment of quadriceps isokinetic force, 60 and 180 degrees per second. And you may see there is high agreement. I would say not a high agreement, but there's a high validity.
Please come to the end.
Sorry?
Please come to the end.
Yes, I'm coming to the end, sorry. There's a high relationship, strong relationship between the parameters of the force-velocity relationship assessed in such way. And something that was done on the patients recovering from this ACL injury, on the data collected from them. And we have the quadriceps assessed at 4 months following the reconstruction in uninvolved and the involved leg. And you may see the difference in the F0 output at the first place. But then we have quadriceps assessed at 6 months. You may see no difference between, no time difference in the uninvolved leg, but there's obvious difference and obvious improvement in the involved leg. So we may say that this 2-point method, which is based on relatively simple and quick procedure, could be used for the assessment of mechanical capacities of the muscles, and it could provide a deeper insight into the muscle function assessed in such a way. The practical implications and applications: simpler assessment, ecological validity, well-controlled experimental conditions, and we could possibly test a whole muscular system rather than individual muscles. But of course, this is something prone to the future research and to questioning, of course. And of course, simple force power velocity pattern as when compared to the classical approach using Hill's method. And of course, like every research, this one also has a number of limitations, but probably the most important one could be, the questions could be the number of loads used, the type of load, the magnitude of load, and of course the range of loads used. And of course, this is the research team behind the project, and I would like to thank, of course, some of the people. And I would like to thank them, and I would like to thank you for the attention.
Thank you very much for the very interesting but specific,
Very specific
lecture.
Yes.
And we got also a repetition of math.
Yeah.
Mathematics.
Yes.
Thank you very much.
Well, you're welcome.
Thank
Any
you.
questions?
No questions because
Thank you very
we
much.
have to be in time. The next is Sredan Dorevic. I hope I'm right. And the new concept of speed and explosive strength training using post-activation potentiation conditions.
Okay, I'm happy that I'm here. I just come from the Doha, so it was quite a difficult trip here. And my background, I have two backgrounds. One is sport, top-level sport. Another one is scientific. And what I want to present here, some practical experience with the idea of potentiation training strategy. In the first part, I will have a short introduction about potentiation myself. And I'm sure that majority of you know what is potentiation. So the main idea is that previous activity of the muscle influence on the muscle response later. So simplified, if you do something which is low the muscle respond in the way that can be a little bit faster or can be slower. It depends of how long we have this event and how intensive it is. So another another definition is the post-activation potentiation is actually more precisely defined the way how we produce the potentiation. Can be produced with a voluntary movement or can be produced by the electrical stimulation. Here is some ideas of how work potentiation, which is physiological. Maybe it's important to see that there's something on the molecular level. Then we have some neural enhancement mechanism, and we have some mechanism which is connected with actually facilitation on the level of the spinal cord and postsynaptic potentiation. In the sport, we have, I think in the last 20 years, there was a few articles, and in the last maybe 5 years, even much more, about the potentiation. But what I want to say is that there are the two different things which is connected to potentiation. One, when you measure the potentiation, and with a different method which I show you, another influence of the potentiation of the certain task, which is not actually measuring with some methodology, let's say, behavior of the muscle. So, generally speaking, we have at the moment 3 different ways how can we measure potentiation. One is mechanical, when we measure the twitch torque. So we stimulate the nerve, and can be surface or can be direct, direct stimulation of the nerve, and then we record the answer, which is in the form of the twitch contraction. So the stimulus is usually between 0.1 and 1 millisecond, and then we actually observe the response of the muscle with the strain gauge on the let's say on the tibia. Another one, it's mechanomyography, when we measure directly displacement of the muscle belly after the same type of stimulation. And the third one is electrical, when we, with the same type of stimulation, measure the electrical response, which they call M wave. So in all three, we have in the some certain similar response of the muscle. This is facilitation and increase of the amplitude of contraction or the electrical voltage. So what actually changed? What is changed when we have this, when we use these methods? One is that after the potentiation protocol, we have changing in the torque, in the amplitude, then increase of maximum rate of force development, shorter contraction time and delay time, but not in all conditions. If using mechanomyography or TNG response, we have quite similar. We have shorter contraction time, increase of amplitude, and delay time, and which is always present, and the increase of maximum or minimum rate of displacement development. In the F wave, we have actually two parts of amplitude. One is positive, one is negative. So in the both cases, we have increase of amplitude and the shortening of the curve, or shortening on the second phase of the M wave. There is the question which I discussed with somebody outside. They tell me, yeah, but potentiation training, it's quite long. We know a lot of time. I mean, quite long present. But in the way how we actually try to explain and practice, it's totally different. What we're doing actually, we're doing the measurement almost all the time between the certain period of the training, which meaning that if we have a training of the same type 2 weeks and they have the similar exercise, I don't know, 2 times per week or even 3 times per week, we measure each 2 weeks or every 2 weeks we measure the muscle response of the certain athletes with a certain exercise. We use the target muscle, which in our presentation will be quadriceps muscle, more precise vastus medialis or lateralis. And then we try to find a short window when we have dominantly potentiation without fatigue. The same exercise, the same method can be used in the exercise with the overload or with the sprinting. So let's say repeated sprinting of the 60 meters and or even shorter, and using the target muscle, which is in this case biceps femoris, but in the let's say in the squatting or half squatting or single leg squatting, it's quadriceps muscle. What is important that the idea of training strategy mainly based on the fact of the fatigue. So we have limitation of the number of repetition, the base of fatigue. 1 repetition maximum, I don't know, 6 repetition maximum. But this means that when we have this, we already come in the area of the fatigue. And fatigue and the fast movement and explosive movement doesn't correspond really nice. In reality, and also the efficiency of training actually suffering. So our approach is with a relatively fast and simple measurement. Try to find conditions with a certain exercise which we use in the training protocol, and try to find the window, the time window, when we know that dominantly we have potentiation. This meaning in reality that the parameters which I explained before actually are growing. So amplitude of contraction on the twitch response growing, the shortening contraction time, shorter delay time, and increasing of the maximum rate of the displacement development or force development. And of this way, we stay dominantly in the potentiation, let's say, environment. So what we need actually to do this, we need a relatively simple method which we can use in between the training or sessions. And what we must do, we must individualize actually the strategy for the certain person. Our experience is that people doesn't respond on the same way on the potentiation. Even the same person in different period respond different. So it depends of the many different things, you know, acute or chronic fatigue and so on. So what we believe that it's, and we have some evidence that are benefit of our strategy, or the strategy of, let's say, potentiation training. One is that definitely that in the many cases when we need high activation level and we have short window between contraction and relaxation, the main limiting factor is fatigue. So what we're trying to do in this type of the training, we try really to totally escape the fatigue. When we record fatigue, let's say in the movement or in the running speed, it's usually late, because even before we can record some changing in the twitch torque or twitch contraction property of the muscle. The good things is that with this strategy, the volume of the training is reduced by the 30%, but the intensity of the training is same or a little bit higher, between 5 and 10%, maybe higher. So how is looking in the reality this measurement? So here is explanation. So here is some simple explanation of. Can we see this? Oh, no. Okay. So here we have the single leg squatting, and on the right side it's here is the parameter which we observe in the mechanomyographical response. Here is the position of the electrode for the M wave. Here is the stimulation of the muscle on the inguinal region for the femoral nerve, and just shortly, here is the typically what's happened with the M wave when we have high intensity of we have, let's say, high load or high intensity of the contraction. So what's happened actually, we can see the amplitude actually growing, and it's a little bit shorter. What we observe the first and second part of amplitude, which behave a little bit different. And on the next one, we have the typical recording of the training. So we measure between the single leg squatting, we measure. So the single leg squatting was performed from on the end. I will show you the movie, but it's squatting from the 0 to the 85 degrees, and the number of repetition you can see here between the, let's say, can be between the 6 and 2 repetitions. So after each measurement inside of 10 seconds, we have the measurement of the twitch response of the muscle. And here you can see some parameters, how they change. So typically contraction time for the normal stationary for the normal situation before the training or before the exercise, and this is after the exercise. And you can see huge decrease of the contraction time. And here it's a little bit change, but not dramatically. But what we're trying to do, we're trying to stay inside of the elevated potentiation parameters. Once parameters start to going down, meaning that the fatigue is actually coming. On the end, I will try to explain something about how these two things happen in the same time. So here is the typical response of the M wave. Oh, sorry. Oops, it's wrong direction, sorry. Okay, so we can see how the change parameters, the change amplitude and time parameters actually change. It's shorter, little bit shorter. Amplitude is a little bit shorter of the M wave, especially the first part, also the second part. Here the real measurement. Let's say with what we are doing in the training on the first, you can see when it's TMG graph, you can see mechanical response of the muscle. So the first curve. Here is on the beginning, before the exercise. This is when the potentiation is maximum. Here is the derivation, or we calculate the max of the rate of displacement development. But here you can see a big difference between these two conditions. So this is derivation of this curve. Okay, then there was the multiple sets. So it was the 3 sets, and in the third set, so this is the first set measurement, second one, and the third one. So in the third one, we can already see some decrease in the amplitude. And here, if you look at the derivation or the rate of displacement, maximum rate of displacement, also a little change. So in these conditions, we recommend to stop with the exercise. So after this one, we should stop because the fatigue start to influence on the muscle behavior. Here is how it's looking on the software. I don't know what you see, but here is the beginning of the exercise. And this is actually the end of the exercise. And in between, you can see even higher response and a shorter response. So the changing we can observe in the time domain and also in the amplitude domain, and really big one. The difference between in the top level sportsman, let's say sprinter, the difference between the steady state and the state when they're and after potentiation can be in the some parameter even 200%. Let's say, especially in the maximum rate of force development or displacement development. Okay, here is just some comparison between the twitch response of the mechanobiographical recording and twitch torque recording. You can see similarities. This is before, after, before, after, before, after, before, after. You can see that here is even more statistically significant change in the time parameters. Okay, here it's some practical, let's say, how it's looking on some top level sportsman. Here is some parameter that we observe in between the measurement. So we combine the mechanical and electrical response and we try to find some algorithm which will distinguish really good the level of potentiation. So in the year 15 and 16, the same person practiced normal training, let's say, with the same strategy of training, and this year they practiced a little bit different training. This is the result of the 60 meters running. This is a female athlete. Here is the number of the sets in the 4 months, and this is the number of sets also 4 months, but with this strategy of training, you can see quite a big difference, more than 30% less of the sets. And here you see the average number of repetition, which is almost the same, a little bit lower in this type of strategy. And on the end, here, I hope that I will know how to do this. Let's say here. I don't know how to activate this movies. Here? But I want to activate the both one. Okay, can you help me? Yeah, same time. So but this usually work. Okay, then, leave one, and then we do another one. Okay, so how is typically looking, it's measurement by self. This is one leg squatting, single leg squatting. Here we measure also the EMG, and we measure also the speed of the movement with the accelerometers. Then inside of at about 10 seconds, we have immediately the measurement of in this case, vastus lateralis. So here is the moment, and down we have short contraction, and what you see before on the curves actually happened. So just on the end, I would like to discuss about this here. This you can find in some articles and ideas about how this functions. Theoretically, what we have what we find after the few thousand measurements on at about 40 sportsmen in the last 5 years, that the potentiation coming much earlier than fatigue, not in the same time, and disappearing much faster than fatigue in this type of exercise. Not here is almost short, it's almost symmetrical, but a little bit before, but in reality, it's coming almost immediately and disappearing almost very fast in a few minutes. The fatigue can stay much longer.
Thank you. I want to thank you for the lecture, because I mean that your method in praxis has really an advantage to the old one. It's a pity that we couldn't discuss. Thank you.
Naj gre za dolgo ali kratko pot. Zdaj lahko poskrbim za svojo družino, ker moje gorivo poskrbi za moj avto. Izboljšani dodatki v gorivih MOL učinkovito zmanjšujejo obloge in tako čistijo motor. Z novo generacijo goriv MOL Evo poskrbite za motor vašega vozila.